Okay. Okay. Thanks, guys. So, just the introduction part again. So, this is continuing on our AI series. So, if you just Google Cochrane, AI as a part of randomized control studies, there are 5 systematic reviews. I think there are so many RCTs, and there are 5 systematic reviews. Right? And if you look at it, there are 2000 RCTs. 2,200 RCTs in which AI was one arm of the RCT, that is augmented intelligence. So that's fantastic. Because a couple of days ago I did this. That's amazing. And if you look at it, it's like AI for keratoconus, AI for primary healthcare, smartphone skin melanoma detection, AI for fetal labor, dermoscopy. These are the systematic reviews, not the RCTs. Well, there are 2,000 RCTs involving AI. So it's clearly becoming the area of need. Now, I was just thinking, like, let's look at one subject by itself. Let's look at neuro. In neurology itself, there are 38 RCTs involving artificial intelligence. So that's what Dan is going to take today. So, and if you look at it, like they have been done over all the years, like, so 2022, 21, 20. So there's a fair mix of these trials every year. So this is just an article which came out in 2023 in neurology, and it's like, what about AI and neurology? So they were looking at 2,45,000 abstracts with AI in them. Of that, about 60,000 AI was used, and then they determined whether the AI was used like in a mature stage where, like, we are doing the ophthalmoscope and we can say that AI can even detect, but you're not paid for that AI module. Otherwise, you take the photo and you give you the report itself. Or it's just a immature stage where the AI is being tried out. So what they found was, of the 5,000, of the 60,000 articles, about 5,000 are mature and people are using in real world. So this picture looks big. So 60,000 is big. Of that, the red is 5,000 is the mature applications. But just imagine 5,000 mature AI applications in medicine are already available. And about just 55,000 are on the way to becoming applicable. So it's a big thing. So I don't know if you can hear it, we stand here. But if you look at it like, so what are the areas in which it's widely applicable? If you just take neurology, this is all the on the x-axis in various subjects. But just look at it from one perspective, from neuro alone. MRI is the highest MRI for AI. We don't use it in CHC, but in world of MRI is leading AI is leading MRI in neuro a lot. Second is EEG. It takes a long time to use EEG, but just making AI needed. Third one is biomarkers in neuro. So using biomarkers and just looking at it. And electronic health records in neuro are a big thing. If you look at some other subject like oncology, it's CT, MRI, histology. So the AI is reading the tumor, reading the histopath and telling you the diagnosis. So it will be different. So for gastro, it will be endoscopy. It is aided by, and for cardio, you may find echo. Today's talk. So if you look at cardio, it's more of ECG, AI reading ECG than echo at the moment. So again, this machine learning, everybody gets confused. So artificial intelligence is just a computer system which will help you. In that, there is machine learning is one type. In that, there is random forest, deep learning, regression, support vector. These are the tools one uses. It's just a technique. Logistic regression, reasoning, all statistical techniques. So when people say that, but people use it interchangeably. And then there's rules which you can use, maybe supervised, unsupervised. So you will not be confused about what is artificial intelligence. If you look at it in neuro, it can look at the picture, the image of the brain, and it can tell you where hemorrhage is there. Then you can also look at scores. The stroke score, also the AI can generate a stroke score. It can also tell you, look at the image and it can circle and tell you, look, this MCA is occluded here. And it can even do ventilation perfusion scans and it can tell you that, look, this patient requires reperfusion, even though he's come of wake-up stroke, there is still some penumbra which can be salvaged. So the AI can do phenomenal amount of things in neuro. This is the same kind of thing looking at the MCA occlusion. And it can also tell you about the area of the brain which is ischemic and which is the penumbra. And is there some area which will benefit if we can open it. Now, this is a new thing. Now, many doctors are saying that I don't have the time to follow up on my patient. So you train your AI on the guideline. So you take an AI, you say, look, these are the neuro guidelines. And then this is looks like a random thing. So this is a patient who's talking on the phone to the AI, and the AI last time has summarized all the information from what the patient is saying. The patient has a long talk, the AI makes a note to the doctor. And then the use of this, so then the computer tells you, my wife has had a seizure and is back to normal. She has a known epilepsy and had it for years. We just took her regular sodium valproate medication. Should we come to the emergency system? They come to the emergency or do another take long thing. Or should I just stay at home? And this is real world. And then the neurologist is telling, we talk to my AI assistant and he will tell you. The AI assistant has read the neuro guidelines. And this is the chat GPT answer, which is based on the neuro guidelines. It's real world. If the seizure lasts a few minutes and your wife has been previously diagnosed with epilepsy, you do not need to go to the accident and emergency or see a GP. However, you should call 999 and ask for an ambulance if the seizure lasts longer than 5 minutes, or if your wife is unable to move one hand or leg, among other severe symptoms. Additionally, if this is the first time your wife has had a seizure, you should seek medical help immediately. And the chat GPT also gave you a reference. So this is the way in which you can train your AI. It's like training your dragon almost like you. This is my read these guidelines, and then the AI assistant is able to augment. So actually, it's helping people to save a lot of money instead of having another 24-hour duty doctor and some AI. Reducing the number of GP visits. Patients also are happy because it sounds intelligent. Then histology, for example, a pathologist is really good to diagnose what is Lewy body. We look at that. And it takes my time in pathology, then neuropathology, and this. The AI is already trained to look at Lewy bodies, and it won't replace you. It will highlight in the slide where it thinks possible Lewy bodies are. And you can just look at it and say that, okay, this is possible Lewy body, or this is not Lewy body. Then just to say, supervised learning is where the computer knows exactly, it's all labeled. This is the height, age, weight, diagnosis of cancer. Semi-supervised is where you tell the computer, okay, this is height and weight. But the other variables in the screen, I don't know anything. You have to deduce what the other variables are from what I've taught you. That's called semi-supervised. Unsupervised is where you just give a set of images, just for example, the previous image, just give the image to the computer and say, what do you think it is? And it may make some sense out of it, that's unsupervised. Reinforcement learning is where the computer says this is Lewy body. Then you tell the computer, no, that's not Lewy body. Then the computer remakes the algorithm and tries, still it gets it accurate. So most computers have this reinforcement learning. That's called reinforcement learning. Artificial neural networks, very important. We put an image, for example, that image of the histology of the brain inside. And finally, in the end of it, it gives you like a logistic regression. Lewy body present, Lewy body absent. It just gives you a binary outcome. So artificial neural network generally are useful when you want to have an output like yes or no. The problem with that, it's like a neuron. You can think of that as a cell body, and there's the axon and various dendrites, and finally there's an output of the neuron. But we don't know what happens inside. The computer has various levels. Like first, it takes thousands of information. Then it decides 500 are useless, makes it 500 information. From 500, it reduces it to 200, to 100, to finally it gives you an answer yes or no. How it does it is by a series of weighting the information. How it weights the information on what is useful, what is not useful, we don't know. So this is a classical example, what's called black box. We don't know how the AI, the artificial neural network does it, but you show an image at the end of it, it tells you this is Lewy body present, Lewy body absent. But it's fantastically used all over the world. It's the artificial neural network. It's basically there are some layers inside. We don't know how it comes. But this is a good example where if it makes a mistake, it will go back to the previous layer and say, should I make some change? Then it go back to the previous layer. So the changes go back this way, but the answer comes back. So this is very good for reinforcement learning. So this is an example of artificial neural networks. So, I mean, we don't have to go into the text, but basically I've explained what the text is all about. I don't want to go too much of the slides, but just remember that when we did diagnostic studies, we have sensitivity, specificity, positive predictive value, negative predictive value. I don't know if you guys remember the 2x2 table we used to have. But because AI came from computer background, they have got different words for it. For example, precision. So when a computer guy talks of the precision of his AI system, what he's really talking about is a positive predictive value. But as doctors, we need to get used to know there's nothing strange about precision. It's just positive predictive value. Recall. We know sensitivity, specificity, they call it recall. So the same word. You have to get used to that. So then, if you have a measure of person's precision and recall, so if you can combine a measure of the sensitivity and this positive predictive value, they'll give it something called F1 score. Now, I don't know if you remember, we did overfitting on the first part. If you do too many variables and try to accurately predict every dot, that's called overfitting. ROC curve we have already done, and they call it ROC curve, area under the ROC curve. And area under the ROC curve of 1 is very good, anything less. They also call it the C statistics or discriminatory statistics. Then there's something called benchmarks against standardized data. So suppose I have a set of test X-rays, and I already know what is TB and what is not TB. Then the AI can use that to learn. So you have give it a series of 1,000 X-rays. I know which under that TB which are normal, and then benchmarks against a known one. The next one is benchmark against real world evidence. So then, for example, that's why everybody wants to come to CHC radiology. Because we have so much of real world evidence, and then the radiologist is always reporting it. And they can see how well the AI performed. So the AI underperformed, and you keep tweaking your algorithm, reinforcing it, it's able to perform. So this is very easy because people have now got standardized database. For even sepsis, they've got databases available in large ICUs. You can generate, you can ask them, can you give me a data set? You can make an AI model, see this is sepsis, this is predict outcome from sepsis. But people have already done that. But in the real world, this is going to work. There's another set of benchmarking. Okay. Now, when you have a new drug in real life, phase 1 or the phase 0 is preclinical studies like animal studies. Phase 2 is safety, to take people without disease. So phase 1 of a pharmaceutical trial is people without young, healthy men are taken. Hyderabad is the global capital of phase 1 trial. Young, healthy men are volunteering for this, take a lot of money, and they see if the drug is safe. Phase 2 is people with the condition. You give the drug in different doses, and you see at which dose efficacy is maximum, but side effect is least. Higher doses will have high efficacy, lower doses will have lower efficacy. Higher doses, more side effect, lower doses, no side effect. You want to get the optimum balance where good efficacy, but no. That's phase 2. Phase 3 is you compare the drug against the best known standard for hypertension. What is the best current drug? Phase 4 is post-marketing surveillance. In AI and research, proof of concept is a retrospective data set. I have a sepsis data set. Does my AI algorithm predict the outcome of sepsis or predict the presence of sepsis? Yes or no? Phase 2 is real world data. I take data from prospectively from CMC and see medicine to does it predict sepsis outcome or not. Then phase 3 is in real world, you put it into a hospital system. You marry the AI into CMC's clinical workstation. And you see what are the impacts of having an AI algorithm in casualty. Does it change our decisions? Does it change our outcome? And phase 4 is phase 3 is when you do multiple hospital systems. Chronic lab, Chittoor, CMC, Vellore campus. Then you may also employ it in all the mission hospital networks. That's another. So when you talk about phases and implementation of AI, it's slightly similar to drug development, but it's also slightly different. So when people do that. Post-deployment surveillance, now we have, let's say we are using the AI for retinopathy, very simple. What happens afterwards? Does it really make a difference? Is it one toy, voice toy, or does it really make a difference? So I just was supposed to do that. Okay. So this is an article from earlier this year, AI and RCTs, and this will marry into what Janvi is going to do. It's looking at artificial intelligence and randomized trials. What did they find? They found 86 studies for a scoping review. Just to describe, scoping reviews, what is it? what is the overall picture of AI in RCTs. When we looked at Cochrane, we found there are 2,200 RCTs available. They have just looked at 86 in this particular study. So, which country do you think is doing maximum AI RCT? China. China has got 30% of the AI RCTs. Next is USA. India has done one. So these are the countries where AI is being done. 30% is China. In that, then there's gastro. So 43% of AI RCTs are gastro, then radiology, then cardio, then surgery, then onc, then neuro, like that. So we can see where the current AI RCT global spectrum is. Where if you want to know where AI is being used, strangely, I don't think it will be gastro, but apparently you don't have experience doing scoping. You just put a scope inside of the AI and tells you like this is. May not be good, maybe good, but that's what they're trying to do. So less experience you can do. So China, USA, okay. Now they just look at it like this. What are the areas in which it is used? So 86 RCTs. Diagnosis is the highest one. Put a scope and help you to make it. So enhancing diagnosis in RCT seems to be the like today's echo. Is it helping us in making a diagnosis? In that, they found that of the 46 trials for diagnosis, there were 34 trials showed that the AI helped them in the RCT. The next is care management, clinical care. Like I gave the example, the AI can be instead of usually at night and answering phone, the AI can give you the answers to you. That's clinical care management. Patient behavior and symptoms. Last week we did the tool for counseling, online counseling. There was not Alexa. We looked at another. We looked at there's a website you can go if you're stressed out. You can talk to the website and it will give you psychiatric counseling as per some guidance. I forgot the name of that we did last time. Eliza. So then, are we replacing the doctor? Well, some of the maximum is AI assisted clinician versus unassisted clinician. So it could be an echo with AI versus echo alone. Less common is AI versus routine care, where there's no doctor at all. Like for example, if your patient falls sick, they can call the doctor. Because of the doctor, there's an AI answering the phone or answering the email. AI versus clinician is little less. So that's replacing a clinician totally. But there are still RCTs trying to do that. So there's only to be a doctor just opposite AI totally. But the maximum number is AI with clinician versus clinician alone. That's where maximum number of RCTs are there. So this is another thing. I just looked at CHIP database on October 2nd, and I found that there are 283 randomized controlled trials with AI as one of them. So of that, I looked at one of them from India. They wanted to know what is study from India. And this is from AIMS Bhubaneswar. And they looked at RAT stands for robot assisted therapy for people who have stroke and upper limb deficiencies. So this is the RAT group gets 30 minutes of RAT followed by 30 minutes of activities of daily living therapy. Whereas the control group just gets the activities of daily living therapy. It's an AI enhancement, so it's not replacing. You have physio, but physio plus AI. And this is how it looks like the RAT therapy. RAT for upper limb using the Arneo Spring robot. Looks very fancy, but that's what it is. And they found significant improvement in upper limb functions, upper limb passive joint motions, and part of the ADL. And some of the WHO quality of life, except environment and everything seems to get better. So this is a single AI RCT for India. So then the last part of what I want to say is, all RCT should use consort checklist. AI is an intervention. So now they made a consort AI checklist. So that's what John is going to talk about. And it looks like this. It's published in Nature Medicine. And this group looked at in Feb 2024, they looked at 60 RCTs and see how many of them fulfill consort AI checklist. So they also came to the same 65 studies. And they just want to look at these RCT, whether they use that consort checklist and the consort AI checklist. So what they found was, again, most of the studies were from China and a few studies from most from North America. India is one, so it's all of one in this green picture. We went through that study. Oh. So the median sample size is 186. So these RCTs are not large RCTs, but 186 is not small. Most of them are single centers, and 4 of them are multi-center. So if you look at the interventions, endoscopy was the largest number, which I told you earlier. Image enhancement, like today's ECHO study, fundoscopy, which we are doing in medicine too, chatbot, mental health interventions for chatbot seems to be a huge deal. Diagnostic support for people, prediction models, drug dosage, lifestyle changes, therapeutic interventions like ADHD or like this phantom limb for people for physiotherapy, ECG, messages to patients, prescription assistance, and some miscellaneous ones. So it's a large spectrum, but diagnosis seems to be a big part of RCT. Among the specialties, gastro was the biggest one, and neurology was not so big. Among these 65 studies, 90 of them have some sort of consort recognition. So it's not too bad. So 65 journals, only 10 of them though they had an AI, only 10 of them reported the use of consort AI. So it's not coming into big vote, though it's a thing there. And of the people who reported consort itself, 92 had effects of consort. There are only 2 journals which mandate currently that if you have AI, you have to use consort AI. That's the Lancet Digital Health and Lancet Gastro, because gastro is a big area. And Lancet Ophthalmology says that you must mention all these things, but they don't say consort AI. So that's a little bit of the consort AI should be used if you're doing AI in RCT. The next thing is that in the abstract, everybody says AI, because you want to sell your paper as AI. Where are people screwing up, or not screwing up, it's a bad word. They don't tell you what AI was used. You use artificial neural network, supervised, unsupervised. The paper just says AI is used. So when you're doing an AI trial, we need to specify all those. So this is one major area where people are falling short. I do AI, but not telling what AI was used. The other area where people are very good is saying that the output of the AI is 80% sensitive, C statistic is 0.9. That is very good in producing that. But where we are falling short is what model, what computer you use, what if you use artificial neural network, what type of AI, what software you use to use that, not the data, can somebody else reproduce the data? That nobody wants to share. So that's where we have to be really more transparent. If you're doing AI, we have to make it clearly detailed that I use this software, I use these codes and commands. So that's what I wanted to say. A little bit about AI RCT is becoming a new hot topic. Mostly augmenting a clinician rather than replacing a clinician. It's more in gastro, mostly for scopies and diagnostic. But it also can be used for AI as a physician assistant and stuff like that. So these are some little backgrounds before Janvi's talk on an AI RCT and using the consort AI checkers.